Speaking on behalf of 100 million Americans is a bit of a challenge. It's 1 in 3 among us, and in fact I assume that I'm speaking on behalf of some of you in the audience today. For those of you who are fortunate enough not to have experienced chronic pain, I want to ask you to do something before we begin. Please think about a time when maybe you had a toothache or pain from a sports injury, childbirth, a car accident, a serious illness. If not that, would you think about just taking your hand and finding a soft spot on your body and pinching it just as hard as you can, and then hold it as long as you can. Now, if you would imagine that the pain you've remembered or that you're experiencing never got better. At its very worst, it never got better. That healthcare professionals didn't believe you. They thought your problem was all in your head. That you lost your job, health insurance, maybe even your family, and you began to doubt yourself. I speak about these issues very often, but it is rare that I have the occasion to speak to a group such as those of you today. You have the capacity to change the current situation, which is absolutely untenable. It's my hope that the stories that I will share with you and the data will compel you to act. There is a moral imperative to address this problem. In preparation for the talk, I began to realize I was possibly in over my head and thought I ought to ask some people living with chronic pain for help. So I talked to a lot of people, and I asked them what they would want to share with you about their experience and what suggestions they would have for you. A few of the stories stand out in my mind. One is a young human rights lawyer who lives in Washington, D.C. and fights for the rights of others every single day, but often cannot get the medications refilled which she depends upon. Another is a professor of bioethics and health policy who also lives with sickle cell disease. He has frequently heard himself referred to as a frequent flyer, a sickler, or worse yet, a drug seeker. And then I think often about an elderly woman that I know who has rheumatoid arthritis so badly that her body is twisted and deformed in ways that are hard to imagine. Yet she refuses to use a wheelchair. Watching her walk actually makes me cringe. These good people are between their mid-30s and their mid-80s. I often say about people who live with chronic pain that they come in every shape, size, and color. The one thing that they have in common is that many of them have been treated very badly by our healthcare system. And they struggle every day to get the care they need, and I would argue they deserve. I wish I could tell you about every person I talked with. Instead, I want to describe in detail one person, which I think her story, frankly, serves as a demonstration of what all those who live with chronic pain experience. Her name is Julianne. Julianne is 74. At age 6, she was diagnosed with polio. She was completely paralyzed for a period of time, but she was one of the lucky kids. She survived and recovered and had a very good early adulthood. She became a teacher, she married, she and her husband had 4 children. In her late 30s, however, she began to have really excruciating back and neck pain and a lot of fatigue. 2 spinal infusions and a number of other interventions later, she was diagnosed with post-polio syndrome. Julianne has lived with chronic pain now for more than 35 years. 6 years ago, she was diagnosed with stage 4 lymphoma and went through chemotherapy and radiation over a 3-year period. She's very grateful today that she is in remission. She lives in an assisted living facility, and with the help of family and many friends, she has lived an engaged and active life. She leads a knitting group that makes shawls for women and shelters to protect them from domestic violence. All year long, she knits woolen socks, and in the winter, she mails boxes of them to children in Afghanistan. She plays bridge, and she loves to go to the opera. A few months ago, her primary care physician, who had managed her pain quite well for 7 years, told her that the state would no longer let him prescribe opioids at her current level. Julianne lives in Oregon. At that time, she wore a patch for long-term relief. She did have a prescription which she used from time to time for breakthrough pain, and she also had a prescription for sleep aid that she used sometimes. Julianne had taken exactly the same amount of medication for a long period of time, and once her pain had gotten under control, she had never asked her physician for increased medication. Her physician told her, however, that although her patch exceeded the 120 milligram dosage equivalent for morphine, he would be willing to renew that prescription. But to do so, she would need to come in at least once a month. Without the medication for her breakthrough pain and the aid for sleeping, for the next month, she began to change. Her life began to change for the worse. When she returned to see her doctor a month later, he told her without explanation that he would no longer be willing to prescribe her medications and that she would have to find another physician. He offered her no help in doing so. However, with the help of the ombudsman at the assisted living facility where she resided, she did get an appointment with a pain specialist a few weeks later. Now, all this time, she's without medication of any kind other than Tylenol. Although her daughter lives in California, she came to Oregon to go with her mother to the appointment to meet with this new doctor. Her daughter told me that the physician was pretty awful to her mother. He told her that the medications that she had been taking were not effective painkillers. He ignored her experience and said that she would just have to learn to live with her pain. I got a call from Julianne's daughter after her father, who lives in Missouri, heard Judy Foreman speak about her book, A Nation in Pain, at an event in Kansas City hosted by my organization. I wish that Julianne's case was an anomaly. You all know that tragically it is not. I was so compelled by the story that she and her daughter shared with me that I decided to reach out to friends and colleagues who had either been on the Institute of Medicine committee with me or served on national boards, people who are recognized for their expertise in pain medicine. I sent an email to a number of people describing the situation and said, hey guys and gals, who do you know in Oregon that might be willing to see this woman and to take care of her? I got a number of responses, but we were not able to make an appointment quickly. Actually, it was several months before we were able to find a physician who was willing to take her. All this time, Julianne was without medication, and she began to spend many, many days in bed. She is now taking the very same medication she took that her primary care doc had prescribed, and her pain is being managed well again. When I asked her what she would want me to say to you, she wrote me back a long letter. I quote Julianne. She said, "It is wrong to deny opioids to chronic pain patients as one of the pain management tools, just as it would be wrong to deny chemotherapy to cancer patients. Cancer can end life by stopping all bodily functions, But I would argue that life can also end when one is in such pain that getting out of bed for any reason is simply impossible. Even though one's heart continues to beat, that is not life either. She went on to say, "We give chemotherapy to cancer patients knowing full well about their immediate and long-term negative side effects, knowing also that chemo can cause death, but we offer it because we know its potential benefits." Opioids are known to ease or erase pain. I do not believe that their potential short or long-term effects could possibly be worse than those of chemotherapy, including death. I have been down both paths. Attitudes need to change. Physicians need to take the lead in educating the public and legislators about the appropriate use of opioids in chronic pain management. Relieving Pain, the IOM report, called for a cultural transformation in the way pain is perceived, judged, and treated. The undertreatment of pain is a societal failure, and there are many, many reasons why. Chronic pain is poorly understood, it is complex, it is often invisible. Healthcare professionals are not trained to treat chronic pain, and many of them feel impotent or worse yet, threatened when they are faced with a chronic pain patient. Although we know that a biopsychosocial approach to pain management is more successful than the current biomedical model, it is not reimbursed. There has been very little financial investment in this public health issue. I would argue in particular into research, whether basic science, clinical translational research, or even quality improvement. Consequently, there is a paucity of data about chronic pain and the risks and benefits of many interventions, including opioids. Worst of all, in my opinion, is that two important public health issues, the undertreatment of pain and the increasing rate of addiction associated with it, the abuse of prescription pain medications, have been pitted against one another. And in the process, the use of opioids has become a political hot potato. I think of myself as an advocate for patients and their families. My work is mostly around policy. Therefore, I've chosen to speak about two policy issues with you today. In an effort to address the so-called epidemic of unintended deaths associated with prescription pain medications, especially opioids, there has been a concerted effort to restrict the supply of opioids in this country. From one perspective, some of those efforts may have been successful. There is data that there are decreasing deaths, unintended deaths, associated with opioids. However, at the very same time, deaths associated with alcohol and drug abuse more generally has increased. According to NIDA, the National Institute on Drug Abuse, we do not see fewer people using drugs for illicit purposes, nor do we see fewer people with addictive disorders. In fact, both of those problems are on the rise. What we do see is addicts choosing different drugs, in particular marijuana, crack, cocaine, and benzos instead of opioids. Simultaneously, we see those living with chronic pain who depend on opioids for appropriate reasons, people like Julianne, having increasing difficulty obtaining their medications and being stigmatized for using them. For a number of reasons, Florida has become a hotbed of drug abuse, in particular opioid abuse. Also, because of its wonderful warm weather, many elderly people and other people who live with chronic pain have moved to Florida and reside there. In 2013, the American Academy of Pain Management surveyed chronic pain patients living in Florida to assess their experience in obtaining medications that they had been prescribed. It was an online survey. Respondents were self-selected, but more than 220 respondents participated in this survey. Let me share just a few pieces of information from this study. Nearly 2/3 had scripts for immediate release oxycodone refused. 1/4 of them had OxyContin prescriptions refused. The top reason, and many other drugs as well, but the top reasons given to them for the denial was that there was a national or regional shortage of the medications, that the pharmacy had decided not to stock the medications any longer, that the pharmacist, him or herself, thought the medication or the dosage was not appropriate, and almost 20% were given no reason at all. Interestingly, the vast majority of the respondents were not first-time customers at the pharmacies. 86% had filled the same script at the same pharmacy before. Nearly 2/3 had filled the same prescription 10 or more times. 98% of them were given no help in finding another pharmacy. It took a significant number of them several days to get their prescriptions filled, to find another pharmacy that had the medication. More than 40% were never able to fill their prescriptions. This problem is not limited to Florida, nor is it limited to pharmacists. Tragically, it is a nationwide phenomenon and includes many in the healing professions. A study done by Carol Upshur, a professor of family medicine and community health at the University of Massachusetts Medical School, did a study and spoke with chronic pain patients. There were 17 focus groups. The subjects came from 4 diverse primary care groups. And the conclusion of her study was that almost all reported feeling disrespected and distrusted, suspected of seeking drugs, having their symptoms dismissed as trivial, and or not being deserving of medical attention. Furthermore, there is increasing data that those among us who are diverse because of ethnicity or age or income, social class, that they bear a greater burden of chronic pain and have more difficulty getting the care that they need. In fact, being black in and of itself is a significant variable associated with physicians' underestimation of pain. As media drives public perception and often policy, I think it's important that we know what the media is saying about chronic pain. Recently, the Center for Excellence in Healthcare Communication for Underserved Populations, they call themselves Checkup, at the School of Journalism at the University of Kansas, reviewed more than 3,200 media stories about chronic pain, including newspaper articles, TV transcripts, wire news pieces, and blogs. They looked at those from mid-2012, when the IOM report was published, to the end of 2013. Their findings are really interesting. Of 961 newspaper articles they looked at, they gathered, they carefully analyzed 154 of them. Checkup found that in those articles, 154, the term addiction was mentioned 506 times, suggesting that newspaper articles on chronic pain really have another agenda. Worse yet, in my opinion, is that many chronic pain patients internalize the negative perceptions and stereotypes about those who live with chronic pain. When they cannot get the medications they need, when they're told their pain is all in their head, they just need to suck it up, or they are fired by their primary care provider, many of them begin to feel that they have done something wrong, perhaps even criminal. Even cancer patients today often refuse to take opioids because they are fearful that they will become addicted. Physicians who are willing to prescribe these medications are also often stigmatized by their peers. In fact, many primary care providers today simply refuse to prescribe opioids. I want to now sort of move towards talking more specifically about a balanced pain policy approach. And I want to say right up front that I don't think there is anything balanced about pain policy in this country. In fact, I think it is the notion is about as real as is the belief in the Easter Bunny. Now, let me say that I don't believe anyone in this room wants people to needlessly suffer. And I know that we want to think this is the solution to this dilemma, that if we just had policies that don't impede patient access and at the same time protect against misuse and abuse, that it would be good. All would be good. I believed that for a while. In 2003, I was involved in an initiative with nearly 24 other organizations, including the DEA and the National Association of Attorneys General, to advocate for this approach. I regret having ever been involved. The notion of balance itself feeds into the bifurcation of this issue. The solution is either this or it is that. And neither of those positions is frankly easy to defend. I want to ask all of you today how much attention and resource you think the federal government has placed on the abuse of prescription pain medications versus the undertreatment of pain. How much attention do you think the CDC has given to the undertreatment of pain compared to the abuse of prescription pain medications? We've already talked about how the media addresses these issues. What do you think? What do you think about a balanced approach? Now, we've come to a place in this discussion where we want to describe opioids as God's own medicine or the devil reincarnate. We know that neither is true. We know that the benefits of opioids are limited. We also know that many people who live with chronic pain characterize these medications as life-saving. We know that there are significant risks associated with these medications when used for legitimate or illicit purposes. But there is also a lot we do not know. We do not know the real rate of iatrogenic addiction. We do not know with certainty if the biopsychosocial model called for in the IOM report will improve outcomes significantly, and if this model is economically feasible. If it's not, it will go nowhere. We do not know if moving to a biopsychosocial model will result in fewer prescriptions for opioids being written and fewer pills than being on the street. We do think so, but we do not know. There is so much we do not know. One of the principles underlying the IOM report, I referred to it earlier in the beginning, is that the treatment of chronic pain is a moral imperative. The IOM report goes further to say that all those in the healing professions have ethical duties and obligations to treat pain. I believe that with all my heart. I do not believe, however, that that imperative means that every patient living with chronic pain should be prescribed opioids. I do believe It means that those who benefit from these medications should have access to them. At the Center for Practical Bioethics, where I work, we regularly say that good ethics start with good facts. Clearly, we are faced with a paucity of facts. Like many, I have eagerly awaited the report that brings us together today, in hopes that it would settle this debate about the long-term use of opioids in the treatment of chronic pain. It will not. However, this debate needs to be settled, and with the proper resources and the commitment of those of you in this room, we can find the answers that we need. Research and more data will not lead to a cultural transformation. Cultural transformation, by definition, is necessarily multifaceted, and it will take many people to be involved and engaged. Although insufficient, more research and reliable data, whether from basic science, clinical translational work, or quality improvement, are absolutely necessary to provide the kind of foundation we must have for a cultural transformation and for more effective and humane policy. Working together, we can change this. We can be part of a cultural transformation. I want to thank you, but before I go, I want to tell you that Julianne asked me to thank you as well.